Tēnā tātou katoa, te lava malo le soifua. Warm Pacific greetings, everyone. I'm Warren Elwin, Chief Executive of Work Counts, part of the WISE Group. Welcome, and thank you for making time to be here with us for this webinar, IPS Employment Support in Drug and Alcohol Services. We have people registered from the UK, from Norway, from the United States and Australia, and of course, all of us here in Aotearoa, New Zealand. I'd like to begin by handing over to Rhonda Robertson, who many of you will know. Rhonda is Principal Advisor, Lived Experience and Peer Project Lead, Addiction at Te Pou. Thank you, Rhonda, for offering to open today's webinar with karakia.
Kia ora, Warren. Okay, I'll start. Paua ki runga, paua ki raro, paua ki tamore nui, no rangi no papa, e rongo he ao paimarere. Kia ora.
Great. Kia ora, Rhonda. Now, who is Work Counts, for those of you who are not aware of us? Well, we help organisations develop and deliver evidence-based employment support. This includes for a range of clinical and employment support practitioners. We see Work Counts as helping to lead a process of social change to see employment support integrated with care and treatment for anyone who's in contact with addiction and mental health services, wherever they're being delivered. It's all about expanding access to intensive, personalised employment support. And so I'm delighted to be hosting this session, and even more delighted to welcome and thank our presenters today, who are working especially late in order to be with us here this morning. It's 9 o'clock at night in the UK. As some of you may be aware, England has a world first, a large-scale randomised control trial of IPS employment support in drug and alcohol treatment teams. The trial has now finished, and Paul and Rob will be providing some of the policy context to the trial and sharing with us their implementation experiences. So by way of introductions, Paul Anders, hi Paul, was the trial manager and works for Public Health England in a policy and program management role. Paul has extensive experience working in senior roles in both the government and non-government sectors. Welcome. Dr. Rob Robertson, hey Rob, was the principal investigator for the IPS and drug and alcohol teams trial, and Rob works as a senior employment specialist in an IPS employment support team in Brighton in South England. So with that, over to you both. We are so looking forward to learning from you as we look to increase access to IPS employment support and drug and alcohol services here in Aotearoa, New Zealand. Kia ora.
Thanks very much, Warren, and thanks very much for everybody who's joining us today. Much as it's a late start, a late finish for me and Rob, I know it's also an early start for all of you, so many thanks. Michelle, do you think, could we have the slides up, do you think, please? Okay, okay, great. So if we can just go to the next slide, please. Okay, well, Warren has given a very full introduction there, so I won't add to that. Rob will introduce himself when the time comes. I mean, just in terms of the structure today, What we thought would work was that I'd provide a bit of the sort of the historical and policy context, say a little bit about the trial design and the outcomes and the analysis. Then I'll hand over to Rob, who will share his sort of operational experience and expertise as somebody who's been leading a very good IPS team in Brighton for the last few years. So if we can move on to the next slide, please. So the historical context, and I think here there are two contexts really. So one is the context of employment support in community drug and alcohol treatment. But I suppose first it might be helpful to do a whistle stop and probably sort of quite patchy tour of IPS in England. So pre-2016, IPS was being delivered in England. It was introduced by people like Dr. Rachel Perkins, who I'm sure some people here today will know of. It was introduced in the late 90s, and there had been some sort of standard bearers for IPS who've been delivering consistently and effectively for many years, but really the availability was quite patchy. In 2016, Dame Carol Black, Professor Dame Carol Black, who's been a health and work advisor to successive governments, published a landmark review, the cover of which is on the right-hand side of the slide, into employment, drug and alcohol dependence, and obesity. She'd identified IPS as being a promising intervention, and that was primarily due to visiting services like those run by CNWL NHS Trust in London, and a very small number of IPS services run in drug and alcohol treatment by NGOs. She identified it as promising and recommended a large-scale randomized control trial, because people will probably be familiar. There's extensive evidence for people with severe mental ill health, nowhere near that level of evidence in community drug and alcohol treatment. Sometime after that publication, NHS England announced the expansion of IPS in secondary mental health services. So that was an explosion of the delivery of IPS in secondary mental health services, which now covers almost all of England. So a massive ramping up of the availability and the capacity. And that same year, so we're coming up to our third anniversary, the IPS-AD trial opened. So IPS for alcohol and drug dependence, that opened to its first clients in May 2018. We've been delivering throughout, closing to new trial participants at the end of September 2019. And at the end of this year, right at the end probably, we aim to publish the trial results. If we go to the next slide, please. So the policy context, the employment gap between the general population and people in community drug and alcohol treatment is large, as you can see on the right. That chart is from 2018, and I think the overall employment rate has dropped over the last 12 months. But the employment rate of people in treatment has been really static. So little change overall, and also little change for individuals as well. There's very little sort of net movement from treatment into employment. It's been a focus of successive governments, but there's been good localized work, but very little progress made across the board. And it's been a priority because we know there's good evidence for mutually beneficial relationships between treatment outcomes and employment. And I think that the caveat there is that the quality of employment is important, which I think is really where IPS being preference-led, I think can perhaps provide benefits that other forms of employment support really find difficult to achieve. I just say that there has been activity in the past. There have been some short-lived programs, nothing consistent, and primarily people access mainstream employment support services. Next slide, please. So to say a bit about the trial design, we had 7 sites. So we had Birmingham, Blackpool, Brighton and Hove, Rob's site, Derbyshire, Haringey, Sheffield and Staffordshire. And if people don't know those places, that gave us a very interesting mix of areas. So we had 2 quite rural counties, 2 quite large cities. We had a London borough, and we had a seaside town and seaside city, Blackpool and Brighton. So areas with somewhat seasonal economies, which I think Rob will be talking a bit about later. We also ended up with a mix of providers as well. That was more good fortune than intentional. But we had a local council, 1 NHS trust, 1 private company, and 4 NGOs. So a very simple 2-arm trial design. It was IPS plus treatment as usual against treatment as usual. And we had about 1,700 recruits. I put in the bottom left of that slide a table just summarizing some of the characteristics of the IPS-AD participants. So we can see there that they broadly reflect the characteristics of the treatment populations in the services where the trial was running. And in the bottom right, I've just taken a bit of a pie chart there from the latest treatment data, because I'm very conscious that there are some differences between the typical treatment population in England and that in New Zealand. So stimulant use tends to be lower. Methamphetamine just isn't really a thing in England. Opiate use tends to dominate the treatment population. So some differences there. If we can move on to the next slide, please. Thank you. So a bit about the outcomes and analysis. So we had a recruitment window that was extended. So it was extended to about 18 months rather than a year. We were offering time-limited IPS, and I know that some people find that idea uncomfortable in some respects, but that in effect was what we were commissioned to provide. So it was up to 9 months pre-employment support, then up to 4 months in-work support. And then just a bit about the outcomes. So the primary outcome is one that's really commonly used in IPS trials. Probably people will be familiar with it. So it's at least 1 day of employment in the open competitive job market, in the 18 months after enrolment. Looking at this from a government perspective, that's not a very useful outcome measure on its own. So we've got a whole battery of secondary outcomes. I think about 13 or 14 in total, but I'll just talk about sort of the main categories. So vocational, including tax and national insurance paid and welfare benefits claimed, health and social functioning, drug and alcohol treatment itself, and outcomes, representations, deaths, and crime. The analysis will be effectiveness, cost benefit, and number needed to treat. And a lot of the future of IPS and community drug and alcohol treatment really hinges on what those turn up, and particularly cost benefit will have all eyes on it. If we can move on, please, if that's okay, and this will be the last slide from me before I hand over to Rob. So recruitment to the trial finished at the end of September 2019. We had these excellent IPS teams in place that we didn't want to sit around twiddling their thumbs. So we got agreement from our funders to carry on delivering, and to carry on delivering on an open access basis. So open to anybody in structured treatment, no randomization. 5 of those sites reopened in November 2019. The last site came on stream quite a bit later in May 2020. You might be thinking that that something quite unpleasant happened around this sort of mid-March 2020 onwards, and you can see that on the chart on the right. The grey line is cumulative jobs, and the orange line is enrolment, and the dotted red line are the lockdowns that we have experienced. And I know that New Zealand has dealt with COVID in a very different way to the UK's journey. But I think the key thing, the amazing thing, is that using the open access service, 34% of the people that have started the service have reported starting a first job, which is 187 jobs secured, and 165 of those first jobs have been recorded after the onset of the COVID pandemic. So you'll see from March 2020, there was a period where we were flatlining for a few months, and then things picked up and they've stayed on that upward trajectory. We've recently agreed delivery with the sites, including Rob's site, that delivery will continue to the end of March 2022, and we hope very soon to be able to extend that for at least a further year to the end of March 2023. Okay, at that point, I'll hand over to Rob, who will share some fantastic insights, I'm sure.
Brilliant. Thanks very much, Paul, and thanks to everyone. Good morning to you, and thanks a lot for getting up early to come and listen to myself and Paul talk about our experiences. Could I have the next slide, please, Rhonda? I think before I get into kind of talking about our journey in Brighton and Hove in setting up our IPS service, I wanted to just kind of introduce the city itself. It's a great city to live in. If you get the chance to come and visit, do come, and you'd have a great time. But I think there's a few things about Brighton and Hove that's sort of worth kind of keeping in mind. It's a I guess for the UK, a large-ish city. We're right down on the south coast of England. We're just above 250,000 people. But it's a city with a few unique problems and issues in terms of employment and securing sort of reasonably paid employment. We're a city with a very high proportion of renters as opposed to owner-occupiers. And yet, you know, we've got higher than national average rates of rent and lower than national average wages, relatively high unemployment compared with the rest of the country, 5.4% in 2018 compared with 4.2% nationally. That's a figure that's only just gone up in the last couple of years for obvious reasons. We're also a city with very little in the way of manufacturing base. It's mostly service sectors and hospitalities. Lots of entry-level jobs and a huge amount of competition for those jobs. We're a city with 2 large universities that, with a student population of about 22,500, 5 technical colleges, and over 60 international language schools. So it's a really challenging job market that we have here. In terms of drug and alcohol treatment, we've got about 2,400 people in treatment at the moment, and pretty much the profile that Paul was talking about in one of the previous slides. It's mostly opioids, crack cocaine, and alcohol. And then somewhat unique to Brighton, it being a kind of coastal city and also a city with quite a large proportion of gay and lesbian people, is we have an additional element of novel psychiatric substances in our substance misuse, and I guess what you would consider party or recreational drugs associated with the gay community. So that's the city. Next slide, please, Rhonda. So I want to talk a little bit about you know the reality on the ground of setting up an IPS service within a drug and alcohol treatment service. And I think it'd be fair to say, when we started 3 years ago, in terms of the service culture, really, there was no organizational culture there's no element in the culture that kind of, so employment is part of recovery. So there was no formal view from the organization. They had at various points in times little bolt-on bits of employment support in the previous 2 or 3 years that was often piecemeal funding that lasted for a year and then kind of disappeared. And often employment support was helping people to find volunteer opportunities or helping people into training as opposed to paid employment. And actually, one of the interesting things that was brought up in Dame Carroll's report, and I think it's reflected very well at Brighton and Hove, is that in the UK, for people in treatment, the people most likely to leave treatment with a job were the people who had a job when they entered treatment. And definitely within the service, as it was 3 years ago, employment was not seen as part of recovery. And so those conversations just weren't happening. And not only that, but there was a very broad spectrum of views amongst frontline staff, people working with those clients, in terms of what role employment had in recovery. Quite often people felt that employment could be detrimental to recovery, in spite of all of the evidence to the contrary. That was a widely held view. The other thing, one of the other things that we noticed really, and that was problematic in the early days, is people just didn't really know who we were or what we did. They didn't know what IPS was. They understood what employment support was, or they felt they had a good idea of what employment support was, but they didn't particularly understand the model. And it took quite a long time for us to, I'd say probably about 6 months. It took about 6 months for the entire service to gain a good understanding of the model, how it works, and how it differs from traditional employment support. Also, staff just had this tendency to do kind of mental pre-screening, where they take quite a risk-averse approach to the whole idea of employment. And it was not uncommon for staff to say to us, "I've looked at my caseload and no one that I'm working with is ready for work." Or they'd say things like, "Oh, this person is too chaotic," or this would be detrimental to this person's recovery, or they're too fragile, or this person has never worked or never could work. So there's a lot of exclusion going on in the minds of the staff. As well as that, I think it'd be fair to say that, and this is something that certainly hasn't changed, if anything, it's kind of got worse within the service, is that people are just incredibly busy. The very high caseloads here in the UK, it's not uncommon for a recovery coordinator to have a caseload of up to 80 or 90 clients. Quite often, that just means that they've got very little face-to-face time with people, and often the majority of their time is spent on the people who pose the highest level of risk to themselves and to others. So very often the staff just didn't have the time to have conversations about employment. And then not only that, whenever they did have the time, if they did ever get the opportunity to have the time, they weren't having those conversations in the first place, and largely because they just didn't feel confident having those conversations. They weren't able to keep up to date with the changing benefit situation in the country with the introduction of universal credit, and also, it's employment, training, and education in the UK is a sector that has constantly changing, with small pieces of funding popping up. There might be some job opportunities or some training opportunities that are around for a few months, and then it all disappears and along comes a new provider. So it's an ever-changing terrain out there, and staff just didn't have the time to keep up with that. So they weren't having those conversations because they didn't feel confident to have them. And then the other thing that has a tendency to happen in drug and alcohol treatment services here is this great kind of mythical ideal of multidisciplinary teams sitting around the table having discussions about clients. Largely doesn't happen. And when they do happen, they're very focused on people who are in absolute crisis and exposed and presenting very significant risks either to themselves or to others. So even where those meetings were occurring, there was no opportunity within them to kind of talk about employment plans for people. And then one of the other issues that we've faced, and it's an issue that we've really had to kind of create workarounds, like all of these things, is clients in the UK just don't feel comfortable disclosing to employers that they're in treatment for drug and alcohol issues. It's a whole area that's had very negative press. Employers quite often don't understand it, even though, in my experience, many of them have personal experience, within their own families or in their own circles. But at the same time, employers are very risk adverse. It's not a protected characteristic in law here, so I think people are quite exposed as soon as they say, I've had addiction issues, and people just didn't want to talk about it. So I've painted a pretty bleak picture there, but I would like to talk a little bit about what we did to address some of those issues. So maybe if we could have the next slide, please. So in terms of the culture, I want to just talk about some things that we did that worked. We knew we weren't going to change the organizational culture overnight. So really, what we decided to do was try and target individuals. And we pretty much worked every angle that we had. We looked at the relationships that we already had with existing staff, and really tried to win those people over first. We also CGL, the provider of the drug and alcohol treatment services in the city here, as part of their kind of mission and makeup of the organisation. They very heavily promote people with lived experience, and we often found that they were key allies, because they were able to talk quite passionately about what work meant for them, and often then they became key referrals or referrers into the service. So really kind of looking to win people over one person at a time. And then in terms of the kind of lack of understanding, we just spent months kind of repeating who we were, what we did, how we worked, who we worked with, how to refer to us, and did all of that with a bit of humour. We tried to shoehorn our way into every meeting that was happening within the service. We joined teams for team days out. We loitered around the water cooler, followed people to the bus stop, pretty much everything that we could, looking for opportunities to tell people who we were and what we did. But I would say by far and away, the most impactful thing that we did in terms of kind of creating inroads is we shared good stories, we shared outcomes, and without a doubt, the best way that we found to do that was to get the people who had made their IPS journey into work to come back and talk to staff and tell staff about their journey, about what getting into work had meant for them. And I remember one particular occasion where a woman that we'd helped get into work, and she'd not worked in a number of years, kind of stood up in front of all the recovery coordinators in the service and said, I've been using this service for 4.5 years. No one once has ever mentioned work to me. This service got me a job in a month. Look at me now. I feel like those 4 years were wasted. If someone had only said to me, do you think you could work? I could have started this journey a lot earlier, and that was an incredible moment. And our referrals tripled the following week. Another thing that really works is you really got to make it easy for people to make a referrer. When we started, we had a referral form. We wanted loads of information about potential risk, about recovery capital, about support networks, and we had a rather complicated form, and we were just finding that people were saying, I must get this form over to you, or can you tell me where that form is, or I'll get the paperwork to you next week. And we realized that we kind of created a bit of a barrier, so we really simplified that now. All people need to do is give us a client or patient identification number and their initials. And we asked that the recovery coordinator have a conversation with them so that they know that we're going to get in contact, and so that they know what it is that we do and how we do it. So we've worked really hard to make it very, very easy for people to be able to make referrals into the service. The other thing that we knew that we had to do really was to upskill the treatment staff so that they were able to have those conversations and raise employment with people early on. And that was a real challenge because the service is very busy, people with very high caseloads. So we had to do quite often just like 2-minute info bursts. So we'd try and grab 2 or 3 times a week, 2 minutes at the end of the morning briefings. We joined staff teams for their team meetings. We ran drop-ins, we ran workshops, we put on training days, just everything to help people to be able to have those conversations, because they just weren't used to having those conversations with clients. And then the other thing, we had to really adapt how we worked in terms of multidisciplinary team working. We found that it was just not possible to get everyone around the table. So we took a kind of a ping pong approach where we would have very short meetings with individuals, take that information, go and speak to the next individual that we need to speak to, and we would move around like that. And our meetings would not last more than maybe 1 or 2 minutes. And any follow-up work that had to be done, we took on to do it, because we just knew that people didn't have the time to do that. And then finally, I just want to say a little bit about disclosure. It is really hard to do IPS without some level of disclosure, because otherwise, what's your reason for introducing a client to an employer, particularly if the employer knows that you work for the service? And we've had to really find a lot of workarounds for that, for that fact that clients just don't want to disclose that they're in treatment. So we'd have conversations with clients around what they were comfortable disclosing, and just work with whatever clients felt comfortable saying. And people would often talk about, maybe family issues or health issues or mental health issues. And so we just work with people where they are. And that would often put us in difficult situations where we weren't having conversations with employers about drug and alcohol treatment, because the client wouldn't enable us to disclose that. But we were having discussions about other related health issues. So really having to walk a bit of a tightrope there, and that's something that continues still now today. That it is not that of probably less than 10% of people are happy to disclose that they're in treatment. So that was and continues to be a big issue for us. Next slide, please.
I just want to break in, Rob, and say we've just maybe got 2 or 3 minutes left.
Okay, great, and that's all I need. You can see I've just put some stats up there about the open access IPS service that we're running. 82 clients referred, 41 engaged. We're currently running at 38% first job outcomes. And if you consider that most of the time we've been operating in lockdown, I think that's pretty spectacular. Very good job sustainment as well, and all with a really small team. There's 1.6 FTE of us. Next slide, please. And I'll leave the very last kind of words to the clients themselves. I just want to share a couple of things that clients have said actually about the service. So one client said, "I never thought anyone would give me a job. I've kind of given up till I met you at one of the groups. Now look at me. I feel good about myself again. At work, they say I'm an expert because I know the local area really well. me an expert. And also then another client, Tim, just said going back to work was really scary. I wanted to do it, but I was scared, I wasn't sure if I could hack it. It all seemed too much to juggle, but the support I got from your team really helped me to believe I could do it. I've got my own place again, my own money, and you can't put a price on that. And I think that probably says more in that paragraph than I've said in the last 5 minutes. I'm just going to hand quickly back to Paul. If we've got time, Paul, we'll just say a little bit about the future of IPS, if we can just squeeze that in.
If that's all right, Warren, I will wrap this up really quickly. Can we just have the last slide, please? Okay, so I think there is a big future ahead for IPS in England and the UK. We certainly hope that it involves community drug and alcohol treatment. If the evidence points in the right direction from IPS-AD, that will make that much easier. And just say in the short term, what we're looking at is not a national expansion, but can we expand IPS into other areas of particular need? So that's the sort of the immediate task, and that is the final bit from me and Rob, I think.
I'll close as we started. Paua ki runga, paua ki raro, paua ki tamamore nui, no rangi no papa, e rongo he ao, pai marere. Kia ora.
Kia ora, Rhonda, and for everyone, kia ora, kia kaha, kia marawanui, hui hui, tātou katoa. Go well, everyone.